right, so as I was saying, if you did not find the bias in the previous paper that we did, the bias is lack of blinding. So that's what we're going to talk about today. So we're going to talk about how to assess blinding, biases that blinding prevents, and then we're going to basically review how the lack of blinding in this paper and what we think this says about the paper's final conclusions. So I just wanted to talk about this really quick, blinding versus randomization, since we hear the two together all the time. We hear blinding, like a double-blinded randomized controlled trial. And so this paper in particular, I think it's important to cover because they did randomize, but they did not blind. So randomization and blinding are usually discussed together. So randomization is a prospective tool to basically prevent confounding variables from influencing the assessment of the variable in interest. So the idea is that we know that patients who have worse baseline characteristics end up doing worse regards to what treatment gets. So we want to evenly distribute them, right? So randomizing does not change anything that happens to them in the future, right? So it doesn't prevent differential treatment. It doesn't prevent people from assessing their outcomes differently. That basically is to say that randomization alone is not sufficient, right? So you need to be blinded and you need to be randomized, right? So the question is, who do I blind, right? We hear double-blind study. That doesn't really mean that much because more than 2 people need to be blinded, right? So participants need to be blinded, clinicians need to be blinded, people who are collecting data, people who are assessing outcomes, and the statisticians all need to be blinded. Great. So they're all blind. So I found this lovely paper that basically gives us empirical evidence on what not blinding your paper does. So they took a meta-analysis, compared 250 randomized controlled trials and put them into 3 different groups. One with inadequate concealment, one where the methodology was unclear, and one where they determined adequate concealment. And they compared them, and they basically found that the odds ratio increased by 41% when they did not adequately conceal it. So that is to say that if you don't blind, you overestimate your effect size by a fairly large margin. So let's talk about the different biases that blinding prevents. So what kind of bias you get depends on who you fail to blind. So selection bias. So selection bias can be addressed by both randomization and blinding. So you assess for selection bias by looking in the paper and finding differences in baseline characteristics, right? A selection bias basically means that you did not adequately conceal your randomization sequence, and so that people could predict what the next sequence was, and so they tried to cohort the groups accordingly. So this can either be from recruiting patients in a particular order to ensure that they fall in specific groups, or selectively enrolling patients in the study only when a preferred group selection is available. And then so we looked at this paper, right, and we looked at their baseline characteristics, and we can say that they're actually pretty similar. I didn't think there was too many differences. So I don't think this paper specifically suffered from selection bias. And now I have my lovely clip art here. So the next bias is your attrition bias, right? So this is what happens when you don't blind the participants of the study. So patients who know they're getting placebos apparently don't like it. And so if you are getting a placebo, you are less likely to follow further in the study. And so then this excludes their data from the analysis. This can also occur with, regardless of blinding, if you have a very potent drug that has a lot of side effects, right? People in the drug treatment group can also follow and cause attrition bias. And so the way you look for this is you look for a differential withdrawal from the study. And so this study, there was equal withdrawal. So I don't really think they suffered too much from the attrition bias. Next one, performance bias. So this is what happens when you don't blind a participant or the clinician. So this means that there's differential interventions or actions performed after group selection occurs. So as opposed to selection bias, we can't see this really objectively in the group demographics like we can with selection or attrition bias. In the setting where groups are unconcealed clinicians can treat groups differently simply due to knowledge that one group is receiving a treatment and one group is not. So in the paper that we just read, the clinicians knew which group was receiving hypothermic therapy and which one was receiving normal thermic therapy. And so it's possible that clinicians were more aggressive in treatment simply due to the knowledge that one group was getting a treatment that was intended to have better neuroprognosis. And this can occur from the patient side as well. If patients are aware that they're receiving a placebo, they may be more inclined to go outside the study and seek out forbidden treatments. So in this case, the participant unconcealment is not that relevant because all the patients were ICU and post-class. So getting close to the end, detection bias. So this is what happens when your outcome assessor is unblinded. So even measurements that appear objective, I usually have some sort of subjective component to them. A clinician assessing outcomes can subtly influence the reporting of results based on their feelings and knowledge of the study. So a great example of this, I think, would be a neurological exam or assessment of like neuroprognosis. In particular, like a lot of stroke papers use the Rankin scale, right? All of these are semi-objective, right? They leave room for subjectivity. In our study, the outcome assessors were the only ones who were blinded, so we have a little less concern for this one. And then reporting bias, finally. So this is when your statistician is not blinded. So reporting bias represents differences in how data is reported or selective reporting or exclusion. So in the case of blinding, this occurs either intentionally or subconsciously because the statistician wants or expects a certain outcome and then manipulates the data to match this. So what do we do if you can't blind? Right, so it's not always feasible to blind everybody. Not every study can have every single person blinded, either ethically or just practically. So what you should do, right, in order to prevent these biases, right, so you should standardize the treatment. So if clinicians know, if you know your clinicians can't be blinded, you should have a protocolized way of dealing with problems so that both groups get treated equally. You should try to remove subjectivity from your outcomes. And then you should consider duplicate assessments. And then you should talk about it in discussion and how you try to address this. All right, so now we're going to talk about this paper specifically. So we'll talk about what they did well, and then we'll talk about what they did wrong. So what did they do well? So the groups are randomized, and the ascertainment of which group patients would go to seemed reasonably concealed. They talked about this in the methodology. Right, and then we can double check this by looking at the demographics and saying, well, they look relatively balanced in terms of baseline characteristics. You know, the age was roughly the same. All of these medical comorbidities, things that we would expect to influence the outcome, seemed roughly equal between the two groups. They did standardize some interventions, so things like neuromuscular blockade, things that you would expect to be an issue with hypothermia, they standardized. And then they blinded one of the people, the person determining the outcomes, right? So this gives us little suspicion for detection bias, right? So now let's talk about what they did wrong, because obviously we wouldn't be talking about it if they didn't do anything wrong. So the clinicians in the study were unblinded for the entire treatment. So this is pretty significant given that the clinicians were making decisions for withdrawal of care and neuroprognostication, along with some other important ICU treatment modalities. So there's a pretty significant risk of performance bias. And as you remember from our previous discussion, it's not one that's really easy to assess by looking at baseline characteristics or withdrawal. So it's hard to quantify just by reading the methodology section. A clinician with the knowledge of a patient being given a certain treatment could easily be more aggressive in treating or be more likely to withdraw or delay care. And I think further, they don't talk about it in the discussion section. So this paper also, through its statistics, has a pretty narrow margin of error in terms of what determines a significant conclusion. So based on what we know about the how unblinding changes effect sizes, I would say that based on this one critical flaw, we should should very heavily question the conclusion of this paper that hypothermia is better than normothermia for patients in cardiac arrest without shock. And that's my reference.
In papers that say double-blinded, what two subjects are they generally referring to?
So it's the most common thing they refer to is participants and clinicians, but it's variable, which is why generally we should avoid using it. So it's not, there's no standardized definition of who's double-blinded when they say double-blinding, and everyone, more than two parties should be blinded.
They should tell you in the method section who was blinded, instead of just saying double, single, triple blinded. They should actually say who's blinded.
Anyone else?
That was very good.
Yeah.